welcome to the FlightBridgeED Podcast series. Hey everybody, Eric back with you. Today we're going to go over a case study regarding a cardiac patient that a few colleagues of mine flew the other night. They brought it to my attention. I thought it was a great case, something that you don't see very often, so I wanted to bring it to everybody's attention. I think the way they treated the patient was fantastic. We've done quite a few case studies over the last 2 months, and we've got great reviews. We've had many downloads, thousands of downloads on those case studies. So I think everybody's really liking that approach. I think we learn better by looking at actual cases and applying our methods, our modalities, treatment modalities to those methods and to those cases. So we're going to continue with that probably every other podcast because, again, I think it's pretty beneficial. So we're going to go through first the case. We'll talk about the case study. Then we're going to go look at the pathophysiology regarding the case, why the patient presented that way, and why the patient decompensated based on that disease process. So today's podcast is called The Nightmare Cardiac Patient, Left Main Dominant. If you're familiar with 12-lead interpretation and you're familiar with coronary artery anatomy, you know that 90% of the population has normal coronary artery anatomy where your right main supplies that right side of the heart, the right atrium, the SA node, and the right ventricle, the posterior wall, and the inferior wall. And we know that in the same patient, same heart, the left main, the left anterior descending artery supplies the left atrium, the left ventricle, the anterior septal lateral areas of the heart. So we know that in 90% of the patients, that is exactly what's going on. If you have an occlusion in each one of those areas, you're going to have a respective change on your 12-lead based on that anatomy and how how and where that thrombus has formed. So let's start with this case presentation. We have a 78-year-old male patient that had an onset of substernal chest pressure, radiated into his shoulder and his back, started at rest at about 9:30 Central Time. He presented to the ER by private vehicle. He stated his pain was about a 4 out of 10. They initially immediately started, did a 12-lead. They identified that the patient was suffering from an anterior lateral MI, had ST elevation in V3, V4, V5, V6, and then 1 in AVL. So we know that anterior wall is infarcting as well as that lateral wall from the superior side all the way down to the bottom. So that complete lateral wall had elevation. So based on that, we know as far as anatomy goes that thrombus formation is actually happening right at the left main circumflex branch bifurcation. It's happening right in that area. Because we're affecting both areas, we're affecting everything downstream. That's affecting that anterior wall, and we're affecting everything downstream on the circumflex branch, which is again affecting the lateral wall. The patient got the standard regimen. He got 324 milligrams of aspirin. He got 300 milligrams of Plavix, PO. He was bolused with 4,000 units of heparin, and then they started him on an infusion, a standard dose of 1,000 units an hour. He was started on a nitro drip at 5 mics a minute, and then they also gave him 10 case at 50 milligrams IV. One of the things that we've noticed in this area, even though a lot of the studies are showing that it's more beneficial to take a patient straight to the cath lab where they can get a stent placed without TPA or thrombolytics, a lot of these rural areas, these rural small hospitals, if there's any type of delay in care, they're initiating TPA, they're initiating these clot-busting medications like 10-case. And we're seeing 10-case used as the primary medication in this area. The patient had approximately 100 mils of fluid. The patient had 2 IVs, an 18 and a 20 in bilateral ACs. The flight crew was contacted, accessed the patient, did a good thorough assessment, did a repeat 12-lead, confirmed that the patient was suffering from an anterior lateral MI, and that they loaded the patient and took off for the cath lab. Approximate flight time was about 20 minutes. During flight, they noticed that the patient's pain started increasing from a 4 out of 10 to about a 6 out of 10. So they increased the nitro drip from 5 mics a minute to 10 mics a minute. Now, everybody listening, if you don't know, if you haven't used nitro drip, that's a very, very small dose. That's a very conservative dose. And I would probably say that if I would have been on that flight, I probably would have shot the nitro drip up quite a bit higher than 5 mics. You know, that's a good starting point. But therapeutic-wise, a lot of times we go higher than that. They stayed conservative, which was absolutely fine, and as we go through this presentation, you're going to see that by staying conservative, I think it saved their bacon. They increased the nitro drip to 10 mics. The patient's initial blood pressure while they started care was 135/71, and then throughout the flight it fluctuated into the 140 systolic. Once they started giving the nitro drip increase from 5 to 10 mics, the blood pressure dropped from 147/79 to 103/65, and there was a heart rate drop from 72 to 51. Okay. 4 minutes later, they have another precipitous drop in blood pressure from 103/65 to 69/40, and that's 4 minutes later. So immediately, the flight crew does what we teach everybody to do. You start with the basics, and what they do is they volume resuscitate. They give him a 600 cc bolus immediately. They realize that preload is a problem at this point. They decrease the nitro drip down from 10 mics a minute down to 5 mics a minute. They give him that big fluid bolus, and they get an immediate return on that, and they have an increase in blood pressure up to 129/78. Heart rate goes from 51 up to 68, and it starts rebounding and coming back up. They're able to get the pain back down to about a 2 out of 10. They stay and keep the nitro drip at 5 mics per minute, and they deliver the patient successfully to the cath lab without any other complications. So let's talk about why this patient presented the way he did and why he went downhill the way he did. So like I said before, when we look at any type of MI, we need to match that with the coronary artery anatomy. And if you've listened to my 12-lead podcast before, we talk about that extensively. And I'm not going to go into that in depth. You can refer back to those podcasts. But we know that each area of the heart is matched with a coronary artery. And we know that the right side, the inferior wall, the posterior wall, is standardly supplied by that right coronary artery, and we know that the septal anterior lateral wall is supplied by that left main artery. We said that this is a normal finding in 90% of the population. So the name of this podcast is The Nightmare Cardiac Patient, Left Main Dominant. And if you've taken any 12-lead classes, advanced 12-lead classes, you know that in 10% of the population, the other 10%, patients are what's called left main dominant. And what that means is that there's a anatomical change that happens at birth where instead of that right coronary artery supplying blood to the inferior wall, the posterior wall, like most people have, instead, patients that are left main dominant, that left circumflex branch that normally stops and terminates along that lateral wall, instead continues around and supplies blood to the posterior wall, the inferior wall, and the right ventricle. Okay? So let's think about how this patient presented. Initially, the patient presented like any other anterior lateral MI that we talk about. And we know that each one of these presentations, based on the coronary artery thrombus, is different. If we have a standard right main occlusion, so a standard inferior wall MI, we know that can cause bradycardia. It could, because with that vessel supplies blood to that SA node. We know that it actually supplies blood to that right ventricle, and we know that in 50% of the populations with an inferior wall MI, we can have an associated right ventricular infarction. And these patients are very preload dependent, and we have to identify very early on in this disease process if they have a confirmed right ventricular infarction. In the left main occlusion, so the septal, the anterior, the lateral MIs, we know that is a vessel that supplies the whole conduction system as far as the bundle branches. So specifically the left bundle branch. It supplies that left ventricle. We know the left ventricle is the most important part of all of our heart because it regulates diastolic filling, diastolic clearing, and our afterload comes from that part of the heart. So we know based on each one of these presentations that if you have an occlusion on the left side, you could have cardiogenic shock problems. You could have a papillary muscle rupture that's blown out from that mitral valve. We could have regurg there. We could have flash pulmonary edema. So I guess what I'm saying is you normally have a certain presentation that matches where that occlusion is. It matches what type of MI that is. So an anterior lateral MI like he presented on this 12-lead, you would start thinking that if he is going to have a problem, it's not going to be a preload problem. It's probably going to be an afterload problem. And if you were looking at advanced hemodynamic numbers, you're going to have a high pulmonary capillary wedge pressure. You're going to have a high pulmonary artery diastolic pressure, and you're going to have problems on that left side of the heart. But this patient presented just like that. So when we look at that, he presented with the classic chest pain, substernal, radiated into his back, into his shoulder. So we need to be thinking about a possible, thoracic aneurysm whenever you have that radiation into the back. But he had no indication that there would ever be a preload problem. So as they were flying along, and because they increased the nitro, remember, patients that have an associated right ventricular infarction, they're extremely preload dependent, and any fluctuation, any dose of a medication that can cause vasodilation, like nitro, like morphine, like medications like that, it's going to cause that container to open up. The right ventricle is already not properly contracting and filling. So if you make that container any bigger, you're going to have major problems, and you're going to have that precipitous drop in blood pressure. That's why we always identify if there's a right ventricular infarction in association with an inferior wall MI. So in this patient, we never had an inferior wall MI. We never had that initial presentation, so we would have never ruled that out. So that's why this case presentation is very rare. It's not something that you're going to see very often, and it'll sneak up on you just like it did them. Now, fortunately, they caught on really quickly. They identified, based on another 12 lead, when this gentleman presented with his drop in blood pressure, they did another 12 lead, and what they found was not only did they have a anterolateral MI, but now they had a big, massive inferior wall MI. So there's only one reason why that would happen. Remember, your inferior wall and your anterior septolateral wall are completely two separate arteries in 90% of the population. And then you talk about that other 10%. And this patient falls into that 10% population. So essentially, that left circumflex branch that's supplying or coming off that left main artery is supplying not only the anterior wall, the septal wall, the lateral wall. Remember what I said earlier in the podcast, where that left circumflex branch that branches off that left main, which normally terminates during that lateral wall, now wraps around and supplies the posterior wall, the inferior wall, and supplies blood basically to the entire right side of the heart. So that's why I say the patient is left main dominant. So if you have a high thrombus formation, really high in that left main artery, you're basically cutting off blood supply to the entire heart, because this patient is now left main dominant. And this is exactly what happened. Obviously, this presentation took a little bit to manifest, but what caused the manifestation? It was probably because they increased the nitro from 5 to 10 mics. The patient's infarct was progressing. That thrombus formation that was blocking maybe a little bit of that left circumflex branch is now blocking the entire left circumflex branch, because we know as that thrombus formation gets bigger and bigger, that fibrogen mesh starts causing a bigger thrombus, we're going to have a lack of blood downstream. So this patient now is presenting with an anterior lateral inferior wall MI. If you ever see a patient, you do a 12 lead and they have an inferior wall MI with a lateral wall MI, that's exactly what's going on. They have they're left main dominant, that left main coronary artery supplying the entire heart. So, if this was a big, massive thrombus real high in that left main, a lot of these times these patients will die of sudden cardiac death. Like I said, this flight crew did an excellent job. They identified this. They did another repeat 12 lead, identified that they had an associated inferior wall MI. They were now preload dependent, and they did a great job giving a big bolus of fluid, 600 cc's, and that corrected the problem. That's all it takes. Now, at this point, there's no reason to not continue care with nitro or morphine. You can still give small aliquots of morphine, or you can give some fentanyl if you choose to, and a lot of places, a lot of clinicians are going that route instead of morphine because of the analgesic effects. We know by treating the pain instead of thinking about morphine as we're using it only for the vasodilatory effects, and then the pain analgesic effects are kind of second. If we use fentanyl, we can use that as an analgesic aspect, and just by calming the patient, decreasing the pain, you're going to decrease oxygen demand. Our supply is going to come up because we can give only so much supply, and so supply and demand may equal out. And so that's kind of the thought process of using fentanyl if you have that resource over morphine. The nitro drip, like I said, is they were using an extremely small dose, and 5 mics is a standard starting dose for these patients. With them giving preload and filling that container up, they remained at 5 mics per minute, which was absolutely perfect. The pain was only at a 2 out of 10. There was really no other reason to increase that nitro. Just don't be afraid to do so. And again, use small increments, but just continue to optimize preload by filling that container with volume. So just remember that this presentation is rare. Remember, if you ever see an inferior wall and a lateral wall in conjunction with each other, that is only because that left circumflex branch off of that left main is occluded. That's the only reason that could happen. Obviously, this patient's disease process, he had an anterior wall, his lateral wall, and then later on, about 2 hours after the presentation, the inferior wall MI presented. So hopefully this case presentation kind of gave you a good glimpse in this style of MI. This isn't something you're going to see often, but if you do see this, just remember that this is the treatment is reducing medications that cause vasodilation, optimizing preload. Once you get that tank filled, then you can start giving smaller aliquots of either morphine, fentanyl, and then continue with your nitro drip. If you have any questions regarding this podcast, you want to have me present any other cases that you've come across, please email me at eric@FlightBridgeED.com. Remember, we have our CFRN FPC book on sale on our website. We've had great reviews. We've had very, very high pass rates by using the book and by using our review classes. Check out our website for upcoming review classes in your area. And again, if you ever have any questions, comments, concerns, don't ever hesitate to call me or email me at eric@FlightBridgeED.com. Hope everybody has a great Thanksgiving, and we'll talk to you soon. We want to thank you for following FlightBridgeED.